How does healthcare spending connect to each other? All right, now I'm going to undermine everything I just said. Right? This is a generalized concept chart. But basically, people looked at this and said, what causes health? Well, about 10% is from healthcare, about 30% from genetics, but behaviors are about 40%, and social environmental factors are about 20%. Robert Johnson's program called Building a Culture of Health, which they've been all over the radio with for the last couple of years, is all about this. And one of their catchphrases is, your zip code is more important than your genetic code for determining your health stats. And there's been ads here about Prince William County versus other counties in the DC area.
You may have seen, literally within the last couple of days, there have been articles in the Post on this.
Yeah, I do some work with Robert Johnson Foundation board member, and they really just concluded this is an issue, and I'm going to tell you why. There's things called social determinants of health. Right? I'm sure there's a graduate school program here in Fairfax in social work or health policy or MPH, and they go all over this. Each classes on this. Food, housing, transportation, the environment, toxins, walkability. If you can't exercise, that's a bad sign for your health. If you're living in a crime-ridden neighborhood and you can't go outside, what do? What do your kids do? Education literacy is actually really highly correlated with health stats globally. Employment and job stability, that's a piece of social determinant of health. This is really what the healthcare system looks like. I lied to you before, on purpose. Finance, delivery, research, public health, social services that affect all of these kinds of factors, social determinants of health, get at, influence all of the health outcomes, and then the entire community. And somebody else mentioned about, something community work, community health, or social service, something. The way to think about this, somebody who's one of those 5%ers, those 1%ers, if you go to the hospital 4 times a year, you spend 20 days in the hospital. You go see doctors 2 hours a week. You go get home health like 3 or 4 days a week for another couple hours, right? That's somebody who's really got a lot of health problems. They're really sick. They're interacting with the healthcare system or healthcare providers maybe maximum 10% of the time. That means 90% of the time they're out here, they're at home, they're trying to deal with their food or their housing or other things. Take their medicines the right way or not. All those factors affect their health. And somebody who's that sick, if they're not doing it right, maybe that's why they're going to the hospital 4 times a year. Jeff Brenner's program and some others, we call them super utilizers or high utilizers, that top 5 or the top 1%. They've had people who were going to the emergency room 400 times a year. That's more than once a day. You say, how can that happen? It happens. They just, they get in the mode and for all sorts of reasons, or ending up at the emergency room and in the hospital at the end of every month because their insulin goes back, so they don't have a refrigerator, or an asthmatic who has all sorts of horrible bouts because he's so poor he doesn't have an air conditioner. You buy him a $50 air conditioner and pay his electric bill. You buy him a little cube fridge to keep his insulin in. You've solved half the problem. If somebody come by every day and make sure they're taking the meds, make sure they've got the right food, those things can go away. How many people here have heard the U.S. spends more on healthcare? I know you have. More on healthcare than any other country in the world, and our outcomes are just like average. Anybody else hear that? I'm not sure Charlotte's heard it. Right? This is OECD, Organization for Economically Developed Countries. Is that right, Barry? OECD? Has done these studies, has all sorts of data they collect from all over the world, at least from the developed countries. And these blue bars are health spending. And this is the United States. And sure enough, percentage of GDP, this is about 16%. We're now up around 17 something. What this woman, Elizabeth Bradley, did, professor at Yale, and one of her colleagues, they looked, well, let's see what the OECD spending on social services is. And they stacked them together. Sure enough, the U.S. comes about right in the middle, right where our health outcomes are. Now, again, I know correlation doesn't prove causation, but I think this is pretty strong evidence. We're right between Poland, Hungary, and Norway, Greece. Right? And from a social policy, budget policy perspective, what it means is every other country spends $1 on health, they spend $2 on social services. In the U.S., we spend $1 on health care, or we spend 50 cents on social services, or we spend $1 on social services, we spend $2 on health care. You have countries like France and Sweden, they're spending 21% of their GDP on social services. We're spending 9%. Let me just go quickly through the ACA because I know we're running out of time. This really is where health policy, budget policy kind of meet, and political policy. Some financing things, Medicare cuts, Medicare payroll taxes, fees. Pharma kicked in to fill the donut hole for Part B, Part D. It's a long story. Where it goes, Medicaid enrollment payments, the low-income subsidies I talked about above, you know, for Medicaid and for above in the exchanges. The Insurance Exchange Prevention Fund. The Innovation Center, actually, since we talked about it, a very unusual funding mechanism, should I call it? You know, this, you guys heard about the entitlement dollars and appropriations dollars. The Innovation Center was funded through a mandatory appropriation, $10 billion over 10 years, which automatically renews. So it's kind of like this appropriation that become an entitlement for this program. Now, Congress can obviously always change that, but bipartisanly, they kind of like where it's going. They just had a hearing on it, and there's been some issues. But the prevention fund's gotten ravaged to pay for other things. It was also $10 billion over 10 years. But the Innovation Center is still going strong. There was also IT spending pre-ACA in the Merit Recovery Act. And then where budget policy and political policy come in here. Barry and I were just talking about it. There was a thing, I guess, in the paper today. Remember the slide said, you know, the more things stay the same, the more they stay the same, the more they change, the harder it is to figure out what's going on. In order to get the insurance plans to sign up to sell insurance plans on the exchanges, part of the ACA was 3 different mechanisms for reducing their risk. Because they didn't know if they get a lot of sick people, if one plan got a lot of sick people, one plan got healthy people, they wouldn't get people to sign up, they get 2 people to sign up. So they put in these different provisions to sort of shift the money back around and sort of make, you know, reinsure, make their risks a lot less. There was one provision called the risk corridors where the money didn't work out really the way it was supposed to, and HHS was going to shift some money from one part of HHS to another to pay the health plans. A senator put in a provision as a way to like undercut the ACA, saying, no, you can't shift that money. They prohibited from spending this money on this function to pay these plans. As a result, all these health plans ended up getting paid 13 cents on the dollar. Yeah, hundreds of millions of dollars. These co-op plans, these sort of nonprofit, state-based new insurance plans that were 25, 13-fold of the first year for partly these reasons, but other reasons. Now it's down to 5 or 6. Primarily that last 5 or 6 was because of this. Now there's lots of lawsuits. The plans are suing HHS and, hey, you really owe us this money. We don't care you don't have it. And I guess the government's may now found some money at the Department of Justice in a fund that they're going to pay them out of. That Barry was just telling me about this.
Treasury Department.
Oh, Treasury Department. Okay. You'll hear a lot about the exchange plans. A lot of interstate variability, but the choices are decreasing. There's some places where there's going to be one choice. Premiums are increasing. The networks are getting a lot narrower. It's looking a lot more like Medicaid plans. Limited choice, lower payments. These things evolve. The Part D plans have evolved also dramatically. There's a lot less choices in Part D than there were when it started 10 years ago. But when it started 10 years ago, there were a tremendous number of choices, a lot more than anybody projected. It's kind of the opposite of what's happened in the exchanges. I'll skip through most of this. Medicaid expansion is the one thing that's going to happen in 17. Going to quality and value, this is what's happening now. What's going on in the delivery system changes. The alignment of Medicare, Medicaid, private payers. I mentioned this, I didn't emphasize it enough. It's 2016. Before 2010, this didn't happen. It was just not how Medicare functioned. And also Medicare now is giving people data anonymized, not about individual. Well, they're giving like the oncology care model practices, the individualized data, or sometimes anonymized, sort of lumped together, give them an idea of what their patient mix looks like. But Medicare used to only give out a 5% sample to like 2 authorized academic centers to do analysis. Now they're giving data out so people can do projections and modeling on themselves for this value-based stuff. Politics, 2016 has been a huge year of rhetoric, particularly around prescription drugs. 17, there could be a lot of action. So working on the Hill, you're going to have a lot of fun. This is just from Politico, a summary. I'm going to mention just one thing here, or 2 things. I didn't mention these words, but I tend to use them a lot. Transparency for data, so getting data out to people who can use it, to help them understand what their world looks like, and holding them accountable for it. Holding them accountable for the outcomes. And you can't do the accountability unless you use the data and transparency. And that's transparency can be for health plans, about how they're performing, doctors about how they're performing, patients about what their choices are. And like what mentioned with the low birth weight demos, you can fix the metric, but it may not solve the problem. So you've got that comes back to the streetlight effect. You guys should Google streetlight effect. It's actually a very funny story about the origin of the name. I'll just summarize. The ACA has brought many changes, but it's going to keep going. And the 2016 elections are going to bring a lot of different things. And that there's a big difference between health care, health insurance, health, and that there's these individual, community, and social factors are key, important. And it's what's these value-based, at-risk providers are now recognizing that they've got to look outside of their walls. The old doctors, and I've still heard discussions like this, they'll say, you can't hold me responsible for what my patients won't do when they're not in my office. The reality is, yes, Medicare, Medicaid, and all those private payers are holding doctors and hospitals responsible for what the patients are doing, and they're sort of incentivizing the doctors and hospitals to go out and try and get engaged with the community, engage with their patients on a more 24/7 basis. Not like being physically with them 24/7, but coaching them and thinking about how to improve the community overall. So that's it. Sorry, Barry, I ran way over.
No, you didn't. That's good.
Okay.
Okay,
Good.
Mike, thank you.
Get these slides out to Barry to get to you. If you have any questions, more than happy to answer anything going forward.
This is a tremendous presentation, so thank you.
Okay, good. I think it's better flipped.
And for me, it's kind of like old home week. I'm just sort of being reminded of a lot of things that are occurring in the field. But if you work as a budget analyst in this area, you probably would not be at Mike's level of understanding, but you'd be expected to be certainly knowledgeable about many of these things because you'd be asked to make recommendations and changes, etc. You'd be involved in reviewing demonstrations and waivers, etc. So, as I said, being a budget analyst is a lot more than running a spreadsheet. You have to have a lot of understanding of the world. And Mike was we had a number of health professionals work with us at OMB over the years. We had physicians, we've had dentists, pharmacists, etc. They get pretty uncomfortable with us because we end up making recommendations not always based upon as much knowledge as you get here. But Mike was always comfortable working in our environment, so I appreciate it.
I didn't come in knowing all this 28 years ago, trust me. I mean, but you know, it's interesting. If you're a young policy analyst, because I work with young guys in our office and people on the Hill or other organizations, and you know, and you just learn this. Now with the internet, it's a lot easier to pick up briefs on the history and learn the whole structure and where things are. But now, I will say, things are changing so fast that it's spinning a lot of people's heads. People who've been around for a long time, people who are just new to this, it's a whole new paradigm. And I think in a very positive way, Stephen, not just trying to, you know, rebutter the bread in a different way.
So we've seen the charts going out in the future where there's this disconnect between income and outcome. And Stephen mentioned the issue of dead men ruling. We have all these things that have been put in place. So the ACA has it's a lot of criticism, et cetera, but it does have in place a lot of potential for helping to sort of twist that graph down just a little bit over time. What happens on November 8th will probably have a big effect on it to a certain extent. Although I think the ACA is going to be, to a certain extent, like Social Security, Medicare, and Medicaid, that once you have this big super tanker lined up, it'd be very hard to turn it in any quick way afterwards. So legislation to repeal it is, unless something is sort of extraordinary happens in political sense, would be very hard to occur. But you can make improvements, changes, and I suspect that's what we heard. There have been lots of changes made in Medicare over the years. Some of them administratively, some of them by legislation. There have been lots of changes made in Medicaid. I would expect to see the same thing in the ACA occurring over time. But thank you.
No, what the ACA did is it set, in the private sector, it set a national framework for private health insurance, which hadn't existed before. It was all done by the states. That's why different states have all different sorts of crazy rules. But Barry's right. It's taking away a lot of the ACA stuff would be very, very hard. I mean, the 20-something million people who have health insurance now that didn't have it before. How do you tell them, well, sorry, no longer, now you're thrown back into the lion's pit? I'd have to move back to Massachusetts.
So you hear the phrase, elections have consequences. Well, elections have consequences.
Oh, absolutely.
So thank you, Mike.
Oh, thank you, Barry.
And
Oh, a travel mug.
yeah, so you can think of us as you travel.